Top Med Talk.
Nick Geriatric here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Okay, our third speaker is Kerin Fielding, who's an orthopaedic surgeon from Wagga Wagga. That town's so good they named it twice. And you know the CanMeds diagram of what a doctor is supposed to be? Well, Kerin's it. She's skilled, she's an orthopaedic surgeon, does hips, knees, backs. She's a great teacher, very popular with the med students and the trainees in Wagga. She's a great collaborator, manager, leader. She's on the RACS College Council. And she's a great communicator, as you'll see soon. Even more to the point, she's a great dinner party conversation and she's a great French cook. So, Kerin.
Thank you, Ross. And how do I start? The surgeon in the room. Oh, my God. Thank you, everybody. Am I the only surgeon in the room? Or is there, Bruce out there and anybody else? No. So here we are, a minority group. Well, I'm actually used to being a minority group because I was the first female orthopaedic surgeon in New South Wales and the third in Australia. So I'm probably in my comfort zone. The reason I was given this talk, I'm not quite sure, but I thought maybe Ross thought I was a weak link, being an orthopaedic surgeon. But maybe I'm not the weak link. I always thought orthopaedic surgeons were the top of the evolutionary tree. And maybe a female orthopaedic surgeon would be really at the top of the evolutionary tree. But thank you for inviting me. And a few things that Don said that did you say not tying or not trying? Because not tying we're very good at as a surgeon. And I was very glad that he was talking about urologists and not orthopods. And I think I'll tell the orthopods on council that they need to get their trainings to do our TIPS course, which is training in professional skills, after watching that. Anyway, what are the problems in our perioperative chain? And I've taken quite a different focus to the others. So we want to have a talk about the chain and what are the points along the chain. We're going to go through it link by link, and where have we got opportunities to strengthen the chain and the links. And we'll go through some of the things that we can help, obviously focusing on the patient. So we're looking at better patient outcomes, reduced cancellations, and obviously we want to think about evidence-based medicine. So that's the sort of outline of my talk, and I'm really focusing on elective surgery today. So here's the chain. Obviously we have a patient in the middle and it's all patient-centre focus. And we have the chain starting with the GP. So I'm going to focus most of my time on this terrible elephant in the room, which is the waiting list. And in New South Wales, it's a major problem. So first of all, I want to look at this space here. So between the GP and the surgeon, and that's something that you guys aren't very involved in, but for us can be a very frustrating point in the chain. So here's a letter from a GP to a colleague of mine, dear Bill. Here with John Smith, crook knee, please fix. And that's actually what happens. In fact, I showed this to a couple of my colleagues on council, and I said, gee, that's a good letter. I usually get, dear Bill, here with Mr. Smith, please fix, not even crook knee. Which makes it very complex if you're purely a knee surgeon or purely a hip surgeon. But if you're a dinosaur surgeon like myself, who grew up in the old days of being a generalist, we actually still consult and we still examine the patient and do that kind of old-fashioned stuff. And so, we would figure that out. But anyway, here we go. So this is a weak link. This is a problem in the circle. The GP to the surgeon. The GPs don't have any tools to assess the patient. They don't understand about triage and which patient is suitable for an operation and which patient isn't. They haven't really been trained in that area. It's a real problem for them. They're so busy doing everything else, and we haven't really helped them to tell us who to refer. And the data sharing is a problem. So, most of them aren't on EMR. I'm a rural surgeon. We have all sorts of problems with all the data sharing across our community. We have a couple of area health services that all send into our one hospital, and so, that is a major problem. And the patient expectation. So, the GPs don't understand that if the patient has a really high Oxford knee score, even though they have an x-ray that looks bad, they don't need to see an orthopaedic surgeon. If they're doing everything and they've got all their ADLs covered and they're comfortable and they don't have night pain, just because they have a bad x-ray, they don't need to see an orthopaedic surgeon. The problem is if they get to the orthopaedic surgeon, they'll probably get an operation, as we know, because we've trained this whole generation of technicians. We have fantastic technicians. These guys and girls can basically operate on anyone who walks in the door, and they do. And it's a problem because lots of these patients don't really need an operation, as we know. So, do we train the surgeons to be better at deciding who to operate on, or do we actually not let them get there? I suggest we don't let them get there. Okay, so go back to the chain. So the patient comes with the crook knee to the surgeon. Okay, so what happens next? So the surgeon, we're going to look at this spot here. Surgeon, obviously, we've got this generation of technicians, and so they're going to put the patient on the waiting list. What else do you do? I'm not remunerated to do anything else. I'm not remunerated to organise anything else for this patient. The way I make my living is by operating. So I'm going to chuck the patient on the waiting list, and I'll see him in a year or two, depending on the waiting list. So let's have a look at that space. I don't know if you can read that, but this is an RFA that we've sent into the hospital, that was sent into the hospital. The patient's name is at the top, and they've ticked pre-admission clinic, and they've ticked they have to stay for 5 nights, and an operation will take 120 minutes. They've ticked all the tests in the boxes, all the tests. No allergies, no information, and it's got here crook knee, right total knee replacement. Not very informative. No ASA grading, no comorbidities, no weight, height or BMI, nothing there. And that is pretty classic, I think, from what I see in our booking office. So no information, just blindly order all the tests, no past history. And the other thing is the consent has to be done because the public hospital demands that the consent form is done when the RFA is put in. And the operation is 12 to 16 to 18 months in the future. That to me is ridiculous, that you're getting someone to sign a consent form 12 to 18 months ahead of time, but the hospital won't accept it if it's not signed. And it never gets redone. It's old, out of date. And does that patient remember anything you've said? Of course they don't. And how many surgeons see that patient back in their office the month before they get their booking date? And I can tell you it's very few. And I have enormous problems with our waiting list office because I demand to see all my patients the month before because I know that, Mrs. Smith with her total knee won't remember anything I've told her a year before. And I do spine as well, and they're even worse. They're even harder to look after. And I've got to see them. I don't feel comfortable with that process. So that's another weak link. Okay, so we get on the waiting list and we hang around for 11 months, and this is the space we're going to look at now. And it can be longer than that. Our waiting list at the moment in Wagga is 16 to 18 months to get a spot on the public waiting list, to get a spot in theatre, on the waiting list. So they may wait 11 months or longer before they actually get to a pre-op clinic. Now, a few years ago, we partnered and trialled an intervention program to try and improve this area before the surgery. So we'll have a little look at that. So osteoarthritis, this one, chronic care program. It was a partnership with New South Wales Agency of Clinical Innovation, ACI, which has this musculoskeletal network. Murrumbidgee Local Health District, which is the local health district for Wagga. Our primary health network, and Notre Uni, my uni. So it was a multidisciplinary care program for waiting list patients, people on the list for total hip and total knee. And we had a coordinator that arranged referrals, and the idea was to get them off to physio, get them to a dietitian, give them hydrotherapy, get a home exercise programs, mental health if it was required, and referring back to the GP to try and sort out some of the comorbidities along the way. And there's some evidence overseas, and in America in particular and in the UK, that if you do that properly, you can reduce the number of people who actually need to have a knee replacement, get some weight off, improve their arthritis, get them fitter, get their diabetes better, and if they don't come off the waiting list, at least they're prepared. And they get better post-op outcomes as well. So these are the patients that we recruited. It's a problem in our area. We were the only rural pilot site for New South Wales. The other pilot sites were metropolitan. And our patients come from a very big area. So we service about 380,000 people, but the size of our area health service is about the size of England. So it's very difficult for the patients to get in. So we did recruit quite a lot of them, but we had quite a lot of drop-offs along the way. And they found it quite difficult to attend. So we had 422 patients in the end. Age, smoking, obesity, as is up there. And they were assessed when they came on to the program with hip-knee scoring, quality of life scoring, functional ADL scoring, and their comorbidities. This is their comorbidities, lots and lots of them. And the age group, and just have a look at that, and the obesity. So very high BMIs. Riverina is, I think, the second highest site for obesity in Australia, the biggest people in the country, apart from one area of Queensland, I think. And then the other interesting thing is that the slightly younger, more obese patients had a lot more knee presentations, but actually their knee scores aren't that bad. And this is a big group of people getting operations, and there's very good evidence that if you do knee replacements on people with knee scores that aren't very, very bad, they actually don't do very well, because the knee they get is no better than the knee they had. And we're doing double the number of knee replacements in Australia than hip replacements. The hips do really well. Hip replacements are one of the top 10 operations in the world. Knee replacements are nowhere near as good. So there were 11 people that removed themselves. Arguably that could have saved us $250,000, but there's no historical comparison to before. So, and those savings never show up on your profit and losses. You just operate on another 11 people. You know what it's like. 4 people did get escalated to surgery, and sometimes that can be a good thing, because we have a lot of trouble getting someone who's really disabled from, for example, a bad hip, that we can't pull them up the waiting list because it's an elective procedure. So then you end up doing something terrible by the back door and saying, well, they've got a subchondral fracture, and you make it up, because you know this person's going to end up in care or something if you don't get it done. We did have a reduction in length of stay for our hip surgery patients compared to control, and that was statistically significant, which is really interesting. And we did have improvement in discharge home compared to in the past. But like I said, it is a very broad rural area, and so sometimes there's nowhere for them to go, like not even Little District Hospital, that most of ours are closed on weekends because of lack of staffing. So some of the issues, the data sharing was a nightmare, no EMR that goes between the primary healthcare networks and so on. Remuneration's really difficult. A lot of those public patients couldn't access physio, some places where there's only private physio. So that made it very difficult. And, we do have this problem in our country where people don't really consider preventative medicine. And, so there's no funding in that sector. So the hospital, it's all about doing operations and getting people through, and they wouldn't help us with the funding out in the community because it's not their area. I mean, you know what bureaucracy is like. And then the waiting list team. So the waiting list office operates completely independently of the team doing the trial, even though we'd really tried to broker this process. And they would just book patients willy-nilly when they're in the middle of the trial program. So that really was a problem. And just so you know, that's me operating there with my husband, who's my assistant, but he's also just been elected to Parliament. So it's kind of cool. I put this message out on Facebook a few weeks ago saying, I operate with an MP. But just to tell you about some of the other places that have done similar things. So Victoria had a fantastic program. They developed this tool, this multi-attribute arthritis prioritisation tool, and they use that in the clinics. Now, Western Australia borrowed it, and they actually used it with the GPs. And so they have this triage program that happens before the patient gets to the clinic. And so they can bypass seeing the orthopod, which I think is very clever. And they're still in the midst of that trial at the moment. So again, similar kind of musculoskeletal networks happening around the States. And the UK, and you know the NICE guidelines, and they've done some work in this area as well. So back to the chain. What's the next weak link? We've found a lot. We're now going to that pre-op assessment phase. So, and this is where you guys come in. And unfortunately, you've been given a lot of hard work in this space. So they get it to the pre-op clinic, and often the nurse sees the patient first, the pre-op assessment nurse, and she orders all the tests that the surgeon ordered when he ticked all the forms. And look, some of them are good. We know that testing for staph is an excellent thing to do and that it reduces our post-operative infections. We know that testing HBs is really important because 16% of our patients in that 420 patients were anemic. And we need to fix that up. But, you know, you get a call to go to the pre-op clinic 3 weeks before your surgery, and you don't have time to get gastroscopies and endoscopies because there's a waiting list for that. So the whole thing's a disaster, mess. We need to fix those up. And you guys are having to manage that at the moment. My anaesthetists in my pre-op clinic in Wagga Base are trying to organise these tests. It's ridiculous, you know, that they're organising scopes and stuff for people. That should have been sorted out as an outpatient. And then, you know, the discussion of ECGs and chest X-ray. The chest X-ray that are never looked at, that no one ever reads, and the ECGs that aren't necessary in those under 65 at ASAs of 1. So we really haven't thought about how we do our testing, and the surgeons, I have to agree, are a weak link in this space. And then those tests that we don't need at all. So coagulation studies, some very nice stuff in the NICE guidelines about, you know, you don't need to do them unless you've got liver disease or you're on anticoagulants. We did, in that group of ours, 7 patients had abnormal coags. All of them were on anticoagulants. Well, you know, we're not stupid. Of course that's what you'll find. So what a waste of money. You know, we worked out that we could have saved $25,000 alone just in cancelling a couple of tests. So we waste a lot of money, don't we, in the system. And then UTI screening. Excellent evidence now that this whole business that orthopods have been doing for years about UTI screening, and if someone's asymptomatic but giving them lots and lots of antibiotics pre-op, there's absolutely no evidence that makes any difference to your outcomes. And I have to say, I batted on about that for years. So, and then lung function tests and gases as well. And that's just a little reminder of the blood guidelines about how we manage our. I think that's a very nice flow chart, and certainly, surely that's something we could send back to the GPs and say, "Can you help us with this? This person needs an iron infusion." And then there's all that other surgical stuff, which I won't bore you with, but obviously is something that I want to make sure I've got all my gear ready. I want to have my pre-op planning done. It's another nightmare in the public system where, you know, you've got a different nurse on today, the different one on tomorrow, and you've put your form. I mean, that form didn't have any instructions. What kind of knee? What company? You know, what are you going to do? And so then there's all the phone calls, and you all know that mess of orthopaedic, in particular, ordering of equipment is a real problem. And the discussion of blocks. So we have this massive problem in our hospital because some of us don't like blocks in our joint patients and some of us do. And so all the anaesthetists are all confused. Who wants what? You know, what are we going to do? And we have not had a team approach about that either. Back to the chain. Okay, so we did the operation. We finally got there. We did the operation. And now we're going to talk about what happens after. So after, you know, we're all pretty good at that. And, you know, here we're going to think about all those other things, you know, VTE and pneumonia, infections, wound care. We're going to think about rehab, improving our pathways. But there's problems with that as Don discussed before, about that post-op care and getting them home, and they're certainly better at home. I completely agree with you. Difficult in our area because a lot of them are a long way away. We have lots of problems with patients wanting to go back to, say, Lake Cargellico, which is 3.5-hour drive from Wagga, and there's only a GP there 1 week in 2. And also, they're usually IMGs. So who's going to look after my wounds? I'm very protective, it's my case. So we'll have all those sorts of problems. So thankfully, we've got physicians and geriatricians around that have been very interested in helping us in this space. And orthogeriatrics is a booming area, not quite so booming in rural, unfortunately. We have one, and he works very hard. But certainly has been something that we've done a lot of work on. With the ACI and the New South Wales experience, we've done an osteoporosis chronic care program, which also includes an in-hospital and an out-of-hospital approach, looking at that orthogeriatric model. And definitely that's made an enormous difference. I mean, my registrars are absolutely hopeless at doing bone mineral density scans and organising stuff for our patients and making sure that these people get treated, because that's not their job. They don't see that as their job, but that's a medical job, which, in my mind, it's part of your holistic approach to the patient. But we've unfortunately lost that. So what do we need to do? What are some of the solutions? We've got to have this multidisciplinary team approach, and getting you guys involved is good. We definitely need anaesthetic help with pain management, and we've been doing that quite nicely in our hospital. But, making sure everyone knows the rules. So this big thing about post-op fever. So we have all these residents running around doing blood culture workups and MSUs and chest x-rays on everyone that has a fever day 1, 2, 3 post-op. But actually, there's excellent first-level evidence that there's absolutely no use doing that in the first 3 days post-joint replacement. I'm talking about, temperatures of 38.5, 39, and the patient's quite well, and they have a post-op fever. It's a surgical fever. There's no evidence at all that doing all that stuff, and the cost of that to the system is phenomenal. So just thinking about how we do it, getting our pathways right. And then we've got the post-op care and back to the GP. So we have lots of problems in that space. We have no discharge summaries that are timely. We don't have data sharing across our region. We have terrible big distances. We have this super specialisation in surgery, so I don't trust any GP to look after my patients' wounds early. So I keep them for longer, or I see them and make the patient travel more. And that's not their fault. That's the fault of the way we've created our super specialty groups. And we have a very, very high international workforce, and they're fantastic, but their training is different. And so, you come from Egypt, and I've been over there and done teaching tours and stuff, and they don't do very many knee replacements in Egypt. So you've been a doctor in Egypt, and you come and work. We have lots and lots of Egyptian doctors in Wagga. We just happen to have this huge group of Egyptians, and they've never seen people with a knee replacement in their country, because it's actually rare, and it happens in the private sector only. It doesn't happen much in the public sector. It's a new and emerging issue. So they don't really have any expertise in looking after those patients. And they'll tell you they don't. And it's very difficult when you're a mid-career GP to start learning a whole bunch of stuff, and they're busy and they don't have time, and a lot of them are extremely remote. Lake Cargellico, 3.5 hours. So that's another problem. Okay, we've been through data sharing EMR. So I think some of the other things that we need to think about is, how do we use this time on the waiting list better? How do we do this early triage and assessment better? We need to help with different tools. Maybe we should get the patient to fill in the tools, do all the scores and stuff when he takes the form into the booking office. But, again, we've got issues in the public. Think about improving those comorbidities early. Focus on the evidence for perioperative assessment. So, as I said, quite a lot of groups doing work in that area. And, of course, the big C, communication and teamwork. and trying to maybe get some locally agreed consensus. How do you do that when you've got a bunch of practitioners who all work independently? I mean, surgeons are one of the worst at that, aren't they? You know, oh, I do it this way because I'm so good at doing knees and that's the way it should be. But, you know, he does it that way. And, you know, all those VTE protocols and things that you can't get anyone to agree on. So that is a big problem. And we've been doing a fair bit of work around that in our hospital, getting the anaesthetists to come to our M&Ms and going to their M&Ms and having multidisciplinary meetings. We started it in trauma, because trauma's kind of like, we all do a bit of trauma and it's kind of not so specialty specific, it really brings us together. So we started doing it there, and then we're starting to branch out in our trauma meeting and have discussions about pain management and perioperative treatment. So getting a champion, someone that can get people together and have some meetings, I think is very important. Oh, they're just my references. And just at the end, I thought you might like to see me with a cake.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.